Karen. There you go. So we'll officially start. So I'm Margaret Robin, and I wear different hats. And for this, I'm both Family Promise of Bristol that works with homelessness, and Appalachian Promise Alliance, which works with particularly with parenting education and community resource navigators in the workplace. Those are two of our big programs. We also do car seats, etc., and some other things. So we want to welcome everybody today, and I know some people are not regular attenders. This meeting started during COVID, and at that point we met weekly because things change so much all the time, and we have continued, and it now goes to every month. We coordinate and try to work with Bristol Coalitions, which has been around many, many more years than that. Originally, their focus was Bristol, Virginia. Now it is a combination of Bristol, Tennessee, and Virginia. We'll ask people to put their information in the chat. Our format is going to be that we're going to hear from Jodi Polaha first on the integrated mental health, and then have Q&A and some comments and discussion, whatever. And then if we have time for important announcements and or some networking, we certainly will do that at the end. Before we introduce Jodi, I just want to go ahead and say that our next meeting will be in March on the 28th at 11. And at that time, we'll hear from Healing Hands and Crossroads for how they're doing this work with integrated mental health. So we're excited to see that happening in our community with those programs. I think it's happening with some other programs as well. So, and then the next Bristol Coalition meeting is March 11th, and they meet at 12 noon, and it's a hybrid meeting. This meeting has never met in person. We have always been on Zoom. And at this point, we plan on continuing that. So, and I don't have the topic yet for Bristol Coalition. I usually get that email on the Friday before, and I try to get it out for people to be able to sign up in time for that meeting. So with that, I will go ahead and introduce Jodi, and she works with ETSU's Department of Integrated Mental Health. Maybe there's more to it. I didn't look up all my stuff. I've known who Jodi was and known her a little bit for several years. She also serves on Washington County Commission. So she's an elected official, just as I am with Bristol, Tennessee City Council. So we have that in common. Also, I'll just say my husband's on, and he said hello. He started working with Jodi. He was trying to remember Jodi if it was 20 years ago or what. It's been a long time.
Yeah.
And I feel like the integrated mental health is a little bit like those of us who are working in ACEs and trauma-informed care, that we know that didn't start catching on till at least 10 years into it, and in our region, actually 20 years into it. So sometimes things take good things.
A little while, yeah.
Take a while to catch on. So we are thrilled to have Jodi with us. She can introduce herself a little bit further. And we'll be thrilled to hear from Healing Hands and Crossroads at our next meeting. And welcome, there are a lot of people on here that we really appreciate the work that they do in direct hands-on, as well as some administrative positions as well. So really appreciate everybody here. So Jodi, if you want to go ahead and say a couple things, and if people, y'all are putting your names, if you want to put your email addresses, you certainly could put your email addresses. I'm supposed to send out the chat every time so people have contact information. I don't always do that. This is recorded. We will put this on our YouTube channel, and I'll include that link in the next follow-up email, but you can find it on YouTube also. So it's pretty handy to have the recordings of some of our meetings that we can go back and look at. So, all right, Jodi, with that, welcome and thank you for being with us.
Thank you so much, Margaret, and happy Friday, everyone. I'm personally thrilled that it's almost the weekend, and excited to be here with all of you today. And especially knowing some of the energy that Healing Hands and others in the region have helped to generate around integrated behavioral health. I'll introduce myself a bit more by telling you a little bit about my career and how I got started. But the long and short of it is that I've been doing this for over 20 years. And of course, I'm super passionate about it. And therefore, anyone else that's passionate about it and starts doing it is my hero, like Healing Hands and some others. And so, you know, anyway, I'm just really excited. And this is called It's Not Your Father's Mental Health. It's like kind of a spoof on some old car commercial or something where, we've really innovated a way of delivering mental health services in a way that we think makes it more palatable, more accessible, and more effective for patients, not all patients, but some patients, and we're excited to tell you more about that today. So by way of introducing myself, I started doing this work in 1997, and I was a fellow in Nebraska at the University of Nebraska Medical Center. I went there because they had this super cool rural program with all these different disciplines, geneticists and occupational therapists and social workers and physical therapists, speech language pathologists that did all this specialty pediatrics, interprofessional work all around the state. We would fly in single-seater planes and we would drive all over Nebraska and see patients in these specialty clinics way out on the on the plains where people, the last people that came through that county were in covered wagons and all of this kind of thing. And I absolutely loved rural work. I had gone and gotten my PhD in clinical psychology in Alabama. That's where I fell in love with clinical work and rural areas and really loved this work. And in the process of being out in these remote places, we would see these kids with these super interesting and sometimes complex medical presentations who the geneticists would say, oh, it turns out it's Fragile X, or, the physician would diagnose this problem, and the parents would be super grateful for that, but also like they would have this whole host of questions like, so how do we get him to keep wearing his glasses now that we know, or how do we get him to do these PT exercises, or what do we do about the fact that he's 10 and he's still not toilet trained, or whatever. And that's when they would say, well, we're so glad you asked because we brought this behavioral person with us. She's a specialist in behavioral pediatrics and she's going to help you with that now. And I would take the family out of the room and we would spend an hour trying to troubleshoot and problem solve. And honestly, it was an hour. And that was all I could give them because they lived 6-7 hours from Omaha where I was living. And at the time when I started, there wasn't any telehealth and there really weren't a lot of options for me in terms of who to refer them to or where they could get some follow-up care. And as I did that work over a few years, I got to know family physicians and pediatricians out in rural Nebraska and hear how challenging their work was, how many kids were coming in with challenges into their primary care clinics, and eventually established a relationship with a rural clinic about 200 miles from Omaha. And I actually drove out to that clinic every week and did 2 days worth of clinic with those pediatricians in Hastings, Nebraska. And I'll just go back to the map really quick. You can see, well, Hastings isn't on it, but it's close to Grand Island. So, it's driving down Tornado Alley and through blizzards and ice storms in the middle of Nebraska to get out there and see these patients. And at the time, we had this system where I showed up on a Tuesday morning and saw patients all day and then spent the night in this comfort inn across the street. And then the next day I would see another 6 or 7 patients and drive home. And, when I arrived on my first day, they had known that I was coming for a few months and they had created a waiting list of patients that could be seen by me. And there were 5 pediatricians in this practice. And the waiting list had 85 patients on it when I got there. So I just told you how many patients I could see, right? Because um, I'm sure you all know psychologists and other mental health providers have to do a 50-minute hour, and we have to see patients multiple times to get them better, right? That's the kind of historical um, standard model of psychotherapy, and that was my expectation. And they kind of gave me some space in the back. But how do you pick which kids to see out of an 85 patient list? Do you take the ones that are the most in crisis? Do you take the ones that are at the top of the list, the bottom of the list? Like, where do you start? Do you take one from each provider, kind of so that everybody's getting something, or how do you do it? And it really turned into kind of a disaster. I thought that I was coming into this clinic kind of like Robin Wright, as an Amazon warrior and Wonder Woman. Like, I'm gonna be this hero. I'm going to save all these kids. Physicians would fill out referrals to me that would get their patient on the list. This is an example of a referral. You can see the panic in this referral by Dr. Sheffield. Like, this is the worst 2-year-old I've ever seen. She's got to get in with this patient's got to get in with Jodi as soon as possible. And I'm this hero, right? Like, I'm going to come in and solve these problems for all these kids. And I used Robin Wright just because one time someone referred to me. They said I looked like Robin Wright, but they said a nerdier version. So, this is the actual picture of me with like my glasses on, right? Anyway, just to kind of come back to this for a moment. I did not feel like much of a hero after several weeks because I could only see, I had, 8 slots on Tuesday and 6 slots on Wednesday. So I could see 14 out of these 85 patients, and everybody else had to wait. And the evidence-based treatments are 10 sessions, 6 sessions. Like, I got to keep seeing these 15 patients, right? That's the model. That's the traditional model of therapy. And so that means that for the next 6 weeks at least, I'm blocked out with these same 14 patients that I saw on week 1, unless somebody drops out, and then I've got one opening, right? And you can imagine by the time I started having openings, like I started seeing these folks and they were actually kind of getting better, that list was back up to 85, and at times it was over 100, because there's tons of patients coming through pediatrics, and those physicians are continuing to add. And I'm seeing these patients in this very slow-paced treatment model that is very traditional to mental health. And it really was quite a problem. And I did not feel like an Amazonian warrior at all. I felt frustrated. I felt like I was making very little difference. And I loved being in the primary care milieu, but I felt like, wow, this is like, I opened this can of worms, right? And I'm not able to really, all I'm doing is creating fights over who gets my next slot. So all this to say, over time, I had to really evolve the way I practiced. Fortunately, there were many others who were evolving the way that mental health practiced in primary care and making it not your father's mental health service. And, you had visionary people like Atul Gawande, who is not a psychologist. He's not a behavioral health provider. I think he's a surgeon or something, coming in and saying, we really need team-based approaches, and we're training doctors to be cowboys, one-man shows. We're training a lot of even mental health providers to be cowboys, one man, one woman in a room solving all the problems. But what we really need are pit crews with most mental health and health concerns. Mental health and health are intricately tied together, as we all know. We need biopsychosocial approaches in which a whole team can walk in and make a difference. And the longer I spent in that clinic in Hastings, Nebraska, and I eventually opened rural clinics all over Nebraska in primary care. I was there for about 9 years, and then I came to ETSU because they were hiring a psychologist to help them start an integrated behavioral health program in 2006, and so have started many clinics in the region since then. We have really evolved that field. So all of this background to say that what I would love to introduce you today is like, what is integrated behavioral health? Why are we doing this? And then what is happening within ETSU's model? And then just challenge you all at the very end to think about what the needs and challenges are going forward if we want to see this model spread in our region. So first, just for those who've not been in touch with or in contact with integrated behavioral health, there's a fair amount of research now to show that mental health concerns are quite common in primary care. If you look at the top 10 things that come through primary care, the top 10 concerns that primary care patients complain about, a few of them are specific to mental health, like depression. That's one of the top things that comes through the door. And a few of them, many of them actually have no identifiable physiological cause. So headaches and back pain and things like this that definitely relate to lifestyle and often relate to stress and ongoing kind of psychosocial concerns. Physicians are often, and nurse practitioners and frontline primary care providers are often those who patients trust the most to ask about mental health concerns, daily life stressors, emotional well-being. We know from the research that primary care is sort of the de facto mental health provider in the nation. About 60% of mental health concerns are raised in primary care, so that's a majority. Are seeking out concern with their seeking out help from their doctor rather than finding a mental health provider to ask. Primary care physicians write far more prescriptions for antidepressants than do psychiatrists or psychiatric providers. And so primary care is where it's happening. It kind of makes sense to start thinking about if that's where people are asking about it, how are we doing on addressing that in that setting? Obviously, I'm going to be talking about ways to do that by building behavioral health into that environment. We think a lot about stigma of mental health concerns and treatments for mental health, and how going to a primary care clinic might help reduce that stigma. And that may be why they're raising the concern with their doctor in the first place, is they don't experience the same level of stigma in that setting. Certainly in rural areas, driving and parking by a primary care provider's door and going in there and getting mental health services provides some cover, right? As opposed to when you're in a small town, your car is parked out of a mental health service delivery provider. And for some patients, that makes a difference. We've done some research now also to show that integrated behavioral health actually makes primary care better. You can see some really significant time savings on being able to introduce a behavioral health provider in the setting. And just to clarify that, about 20% of patients seen in primary care are going to bring up a problem related to mental health, emotional well-being, daily life stress. 20%, 1 in 5, that's like 1 an hour. And we know for those visits, primary care providers end up spending on average about an extra 10 minutes. Kind of troubleshooting and sort of trying to be present for patients who are struggling, coming up with some kind of helpful advice and suggestions, talking through options, looking for community referral options. It's an extra 10 minutes. And so if you average it across every patient for the day, it's 2 minutes. But if you think about it just in terms of 5 or 6 extra 10-minute sessions per day, which is what it comes out to, it's an extra hour of work for primary care providers every day to grapple with psychosocial concerns that are coming up in their primary care visits. An extra hour that, if you know anything about primary care environments, those physicians don't really have, or nurse practitioners or any frontline provider. So there's very busy settings. They're very, there's a lot of demand for primary care. In the practice that we did this study in, which was in Marion, Virginia, is a very busy pediatric practice. They were able to leverage that hour of extra time. So they're not talking to the patients anymore about behavioral health concerns, because what they're doing is they're saying, oh my gosh, I'm so sorry to hear you're struggling with this. This sounds really hard. I have a team member here today that I'd like to introduce you to. She's right down the hall, and she knows all about how tough it is when you're not sleeping and you're dealing with all of these things. I'm going to go get her and introduce you to her. So it's about 2 minutes of making a warm handoff introduction instead of 10 to 12 minutes doing the intervention yourself. When they saved that time and they had an extra hour, they were able to see more patients in the form of walk-ins, and they were actually able to generate about 40% more revenue on those days. And this is a study that appeared in Southern Medical Journal. Happy for you to go look for it, or I'm happy to also, at the end, I'll share my email and I can send it to you. But the revenue they generated actually pretty much offset the service that the behavioral health providers were giving in that setting. We also know that when a behavioral health provider is providing care alongside medical providers, everyone's learning. Everyone's skill sets are leveling up. The behavioral health providers are getting smarter about primary care interventions and being able to provide patients with some sort of if-then scenarios, and of course, bring primary care providers in when needed, and vice versa, right? Primary care providers are learning a whole bunch of little bits and bobs of technology around behavior change intervention. We find that our residents in our College of Medicine settings prefer to learn from behavioral health providers in the context of clinical care, as opposed to in separate lectures in a room somewhere. So we have a really well-researched and well-described and articulated micro-teaching practice that we do, where we engage residents in learning about evidence-based treatments in behavioral health while they're in the middle of caring for someone, rather than, in the context of, we still do didactic lectures here and there. It's not like we're replacing that, but it's a very strong supplemental approach. And then finally, when we're taking 10 minutes, we're saving you 10 minutes on a patient. It's not just so you can run around, see more patients. That's what happened at the pediatric practice in Virginia, where we did the study. It could be that you save that 10 minutes and finish your notes for the day, or it could be that you save that 10 minutes and cumulatively you go home early, or you get a chance to do yoga during the lunch hour, or eat your lunch, or whatever it is. The point is, we think that this partnership and this kind of strong teamwork approach allows our primary care staff and providers to experience some resilience in a very challenging environment. They have a team member present to kind of console them and support them when really tough patients come in, patients in crisis, etc. They have folks around to help them make structural changes to the practice, improve screening around mental health services, and improve the way that happens. And just overall sort of provide some buoyancy in the clinic. So there's some evidence there too that having behavioral health providers working alongside medical providers decreases stress and burnout in that environment, which is ever more important in healthcare. Have any questions popped up as we've been going along? I have to admit, like, I'm in the moment here and okay, keep going. But surely go ahead and put some questions in the chat box if something pops into your brain that you're curious about, or I've challenged some fundamental thought that you've had and you want to know more about it. And I'm happy to answer that. So the next section is like, so what are we doing at ETSU? I'll just back this up for 1 second and say several years ago, about 5 or 6, we had an opportunity with some funding through TennCare, and we approached the dean about building out behavioral health services into all of our College of Medicine and College of Nursing clinics. And we did this proposal and he thought it was great. So that's what we started doing 5 or 6 years ago. We had integrated behavioral health here and there. We had a day of a social worker here. We had a full-time psychologist there, but nobody was talking to anybody and it was very scattered. Today we've got a built-out system. And so I'm going to talk about that built-out system now, kind of describe it for you. And first, just kind of qualify that by helping you understand integrated behavioral health and our version of behavioral health in a more detailed way. This framework was put out many years ago by SAMHSA to describe sort of levels of collaboration. And integrated behavioral health can happen in minimal collaboration levels where you have separate systems, separate facilities. Mental health is over here, primary care is over here, but there are some ways in which, if you look under basic collaboration from a distance, there are periodic focused collaborative efforts. There's perhaps roundtable meetings once a month to discuss some shared complex patients. There could be perhaps some ways of collaborating through notes or navigators or other processes. And then as you build a navigator in, or you build a care coordinator in who has more of a liaison type of role, you get into these basic on-site collaborations, or even these close collaboration, partly integrated models where you have a sort of co-located services and you're seeing each other as you run to the bathroom between patients, and you're on the same site, and maybe you're even using the same EHR, but perhaps mental health is still a traditional mental health service. On the far right, what you're seeing is really what ETSU is striving for, which is a fully innovated model of delivering behavioral health that looks quite different from traditional mental health. It's not a specialty mental health service. We're not offering like long-term psychotherapy for people. We're not even really always worried about improving mental health. What we're trying to do is improve primary care and improve health outcomes. And we know that mental health outcomes are firmly associated with that, and that is part of the goal. But it's sort of almost subsumed under the goals of primary care in general. I won't read the slides to you, and I know this is being recorded. I'm happy to send slides and whatever all you need, but I wanted you to see that there's this full range of ways of integrating. They're all valid. They're all great. Any step in that direction is a good step in that direction. And frankly, integrated care should always be set up in a way that is like optimal for what primary care needs, what kind of funding you have, and it's going to be different in every setting. And for some settings, a version of this might work better for others. And we have a range of implementations in our own system for sure. So I just want to challenge everyone on the call to think about, what does this innovative model look like? On the left of your screen, you can see some of the takeaways that we've gotten from years of primary care being separate from mental health. And learning a lot about what happens in primary care. So we know primary care provides the most mental health care of anything, anywhere. It's where most of mental health services are happening. And the implication that you can see on the right there is that if we're going to innovate and be in primary care as behavioral health providers, we're going to have to be prepared to see a lot of patients. And if you go back to my example from the beginning, from 2000, when I started doing this work, 1998, I wasn't prepared for a high volume of care. I was prepared to see 13 patients a week. And even if I had been there full time, a full-time provider in specialty mental health usually only has 25 or 30 slots available. You're still not going to be able to meet the need of 5 full-time pediatricians who are uncovering 1 in 5 patients with a psychosocial concern, right? So there has to be a different way of delivering care. In mental health, you go down to that second row, you notice that, well, in primary care, you notice that primary care providers treat all ages and all type of psychiatric conditions. So the implication is that mental health needs to follow a generalist approach. And so folks who want to work in primary care can't just see depression or just see anxiety or just see pediatrics. We have to be prepared to see everything. Behavior factors into all kinds of primary care visits in myriads of ways, everything from someone who needs to make a lifestyle change, stop eating as much, start exercising more, to people with complex mental health concerns. So on the right, you can see the implication there is we need to help with more than just diagnosable psychiatric problems. We need to have all behavior change technologies in our back pockets and be ready to see lots of different kinds of things around behavior. On the left, you see the takeaway from primary care is long wait lists are a barrier to specialty mental health. So we can't do what I did in Nebraska and start with wait lists and have people sitting around waiting for 8 to 12 weeks to be seen. We have to find a way to be more available, more accessible. On the left, you can see a lack of resources can be a barrier, specifically insurance and pay, but also perhaps additional appointment times, transportation, et cetera. That's why on the right, we try to minimize resource demands on patients. An example is when someone's in to see their physician and they have a concern, we try to help them with actual therapy that day, rather than saying, here's another resource demand, come back for another appointment in 2 weeks. Instead of doing that, do you have a little time today? Can you stick around for another 30 minutes? Let's sit down and try to get something today that you can start with. And we also know, like from historical experiences with primary care, negative experiences and stigma are barriers to mental health services. So in primary care, we try to look different and act more like a healthcare service. We see patients in primary care exam rooms. We don't move them to a different part of the building when they're seeing one of our providers. And we do lots of other things to kind of look and feel more like a healthcare provider. Improving identification and treatment of mental health problems could lower costs. So we help primary care do that through screeners and other methods. We know that primary care is a tough environment right now, a very high demand. So we don't stand around talking to primary care providers for 15 minutes about patients they've referred to us. We try to move quickly and reduce and subtract from their workload so they can do other things, like I mentioned earlier. And then at the bottom, you have most primary care team members have insufficient training and behavior change. We try to bolster the team skill and give them more opportunities to learn about behavior change interventions. Gosh, I had another thought that as I was going through these, I thought I should add one more row. Now I can't remember what it was, but it'll come to me in time. I'll I'll think of it. So I'll just kind of go through the slide a little bit quickly. You're all kind of thinking now, like, so what is this great innovation? We use this model that's well established. It's been around for a long time. It's called Primary Care Behavioral Health, or PCBH. And the acronym that describes how we practice is GATHER. We practice as generalists. We see all comers. We could see everything from someone who's having trouble sleeping at night to someone who is in crisis around depression and some sort of family issue. We stay very accessible. We only book about 2 or 3 30-minute follow-up appointments in a half day, which means we have all the rest of that half day available to see someone who's in the clinic today with their provider who wants support and problem solving. So we can go there and be there in the moment. We're very team oriented. We have a lot of communication with our providers. In the mornings, we go around and talk to all of them about the patients that are on their schedule. We kind of like preemptively start the wheels turning around who we could be helpful with. We try to stay super busy. Our providers try to shoot for 4 to 5 patients in a half day. That's a behavioral health provider, hopefully seeing 10 patients a day. We do a ton of education with our providers and vice versa to keep the wheels moving. And we use routine screeners and pathways to make sure those referrals are triggered and that we're staying engaged with patients who are in. This is just a little reference point. There's lots been written on the PCBH model, and I could talk about that all day, but I just wanted you to know it's kind of, it's not your father's part, right? So a few years ago, we pitched to the dean, like, we should have this institute and we should build out these behavioral health providers in all these clinics. And then we should have this institute that provides centralized support and capacity building to help our mental health providers do this innovation in primary care. We should go out into the region and provide technical assistance for organizations like Healing Hands that are trying to get this off the ground. And we should train behavioral health providers to do this work so that when a primary care practice in rural Northeast Tennessee wants to try to get integrated care going, we can say, oh, if you hold on until May, we have these great people that are finishing these various behavioral health degree programs that we can send to you. So, when we started, we had these clinics in these different departments, and they were all kind of siloed, and some of them had behavioral health services and some didn't. And this is how we imagined the Institute would connect them all. And I didn't draw the lines, but hopefully connect to community-based clinics. And we have quite a few community-based clinics that we have worked with to this point. This is just some of our founding psychology staff with Dean Block and the ever goofy Joey Tutroni, who has to give someone rabbit ears in every photo. We have a model for return on investment that certainly hinges on fee-for-service billing. Fee-for-service billing is a problem in all of primary care right now. It doesn't really generate enough revenue to do anything. But we also try to leverage value-based payment contracts that have behavioral health contingencies built into them. We also try to do a lot of shared medical visits with providers and use screening tools to justify behavioral health providers. You'd have paid a lot of money if you use your screeners, but people don't always like to use them because they uncover depression and they uncover alcohol abuse and they uncover postpartum depression and all kinds of things. But if you have a behavioral health provider on site, you can justify using the screeners, generating revenue with the screeners, and then using that revenue to offset the cost of your behavioral health provider. And like I said, we think it ultimately has some indirect benefits and values associated with it that have to do with provider burnout and sort of happiness in their work. We've done lots of technical assistance. Later on, I'll just remind everyone that we do have an ECHO program that provides a once monthly webinar that might be of interest to some of you around behavioral health topics in primary care, and I'll show that to you in a minute. We've had some huge grants to develop the behavioral health workforce, and I'll just fly through some slides. Our federal grant, which is just wrapping up, about $2 million. We've trained 62 behavioral health provider graduate students from psychology, social work, and psychiatric nurse practitioners. Of those 62 providers, 60% stayed in the region for work. Really proud to have Courtney Colobro on the call today. She's a psychiatric nurse practitioner. I didn't name that trainee type, did I? We also trained psychiatric nurse practitioners. She was one of them in one of our early cohorts. In fact, I think you're in this picture. Or if you're not, you're in one of these pictures. Oh, this is this year. Sorry. I didn't put your year in, but we have pictures of all of our cohorts over the last 4 years, 62. 60% of those have stayed. Courtney is a great example of one of them who stuck around and has continued to provide services, and really is a frontline sort of pioneer in that she's starting integrated behavioral health services in a clinic that hasn't had that in the past. So we're really happy about that. And so I'll just wrap up. All of these students are placed in these clinics where we're doing this progressive model. They're learning how to do brief and focused interventions, single session therapy sessions, and really engaging. Oh, I thought of what I was going to say, but now you're distracted by this slide. Earlier, when I had this slide up where I was talking about things we've learned about our current primary care and mental health systems and the implications for those. Does anyone on this call know what the modal number of visits is for someone who goes out of their way to get a mental health service? How many times do they show up? If they say, like, I need mental health, I'm going to go get some mental health services, how many visits do they attend? What's the modal number? Anybody know?
We have
It's
one.
it's one. Yeah, it's one, which is probably not shocking to anyone on this call, but like lots of people are like, wow, these evidence-based treatments were developed for 6 or 10 or 12 or 18 or 32 sessions, and it turns out that no one really asked patients, like, how many visits are you interested in coming to? Turns out the answer is like one. Now, there are plenty of people who, really get committed and they are willing to attend several visits, and that's great. And we love leveraging all of our community-based mental health services. Tim, your clinics and many others are really important services that we have in our community for people who are like, we really want mental health service. We want to go to we need ongoing therapy. We can provide a few follow-up sessions in primary care, but if we get wrapped up in 8, 10, 12 sessions with somebody, then, we're back to the start of my talk, right? We've got waiting lists because whenever I'm in a room with someone, I'm not on the floor with someone else, right? And the need is constant in primary care. And so we try to, adapt behavioral health so that it can be a one session thing if that's what people are in for. And they're there, they're distressed, they're talking about a problem. We don't know if they are willing to be seen for lots of sessions. And so we just plan for one. What can we do today? What are some components of evidence-based treatments that we know work? And how can we bring them into this person today? And then if there's an interest in coming back to see us, if there's an interest in being referred to a community service, by all means, like, that is part of what we do. Single session therapy, by the way, is the evidence for single session approaches is growing. It's really new and weird to people around here, but it is something that we've been really keeping our students and faculty up to speed on, and trying to work and leverage as much as possible. And this kind of leads into my last slide. So the challenges going forward are, first of all, just workforce and not having enough providers to serve in any mental health delivery capacity, whether it be at Frontier, whether it be in a number of other clinical service delivery programs for mental health or in primary care practice. And so growing and developing a behavioral health workforce is really important. Historically, we've had people get master's degrees and PhDs, and those take resources and time. And so there's a big emphasis now, and we just applied for a huge AHRQ grant, $25 million through the UT Health Sciences Center, but ETSU will play a prominent role in exploring what people can do at the bachelor's level. How much behavioral technology can they learn? What can they intervene with? How effective can they be? There's emerging research on that, and we're trying to see if we can build up a bachelor's level workforce that can be more effective. And then that could create a more stepable pathway for the workforce in the future. As I mentioned earlier in my return on investment slide, like the fee for service model is not very functional. It does not, billing for encounters does not cover a behavioral health provider's salary and benefits or overhead costs at all. And that's true whether you're in integrated behavioral health or anywhere. It's not limited to this model, but trying to figure out how we're going to keep this sustainable is a huge challenge going forward. And that's a whole talk unto itself. And then finally, stigma around services remains a concern. I mean, as I said earlier, being in primary care can help patients feel more comfortable, but we also need our physicians, our nurse practitioners, our front desk staff, and our nurses, and our MAs, and our people, and our lab techs. We need all of those people to be able to talk with patients in a way that is really open about how we can be helpful in providing expanded healthcare services in those settings. To the extent that our medical providers still see behavioral health as this sort of rigid thing that just addresses psychiatric concerns, or it has to be many, many visits, one-on-one, long-term, and that's the only way people are going to get better. So I'm not going to leverage our behavioral health consultant because they don't do that. We still run into basically barriers with sort of overly stereotyped and stigmatizing views that our providers have that limit who they bring us in to meet. And we need them to introduce us in order for that model to be effective. So like ongoing education and lots of exercises and practice and conversations with those providers is really key. But I just wanted you to know, like, it remains challenging. I'll just say once that we have these ECHO meetings. They're the first Friday of every month. They focus on behavioral health concerns that come up in primary care and how a team approach can be effective. They teach little bits and pieces to primary care audiences, and behavioral health providers tend to learn things too. You can email Melissa Hood and she'll send you the links for getting signed up for those if that's interesting to you. We often have providers from all over the region on those calls. This is just me and my email address. So if you want to reach out to me after this call, I'd be more than happy to talk to you. And I think I may have left a few minutes for questions.
I think you did, Jodi. So thank you very much. And I feel like this just kind of skims the surface. There's a whole lot more and a whole lot more to think about. So any questions or comments from anybody on to start off? So I have a couple. One is so primary care physicians, a lot of them like to do the mental health part. So are there issues sometimes that they hate to give that up? Or is that usually training? They've got so much to do that they can still develop those relationships and it works fine.
It works fine. It's funny. When I was a total novice, I totally did think that like primary care providers didn't like this part of their job, and that's why they would hand off all their patients to me. And I quickly learned that some don't like it and some do. And a really good behavioral health consultant that, spends time building relationships with providers will empower everyone. And then they kind of like will build their service in very like kind of micro nuanced ways to fit with each provider in that practice. So, for someone who hates behavioral health concerns and feels super uncomfortable when they come up, there's some training around how to talk about this stuff and then bring me in, right? And then for people who love this area and want to explore those topics with patients, there's just discussion around how to empower that. What technology do we have that might even make it strong, your work stronger, more sophisticated and elevated discussions about treatments that physicians can deploy. And then they kind of make their own decisions about like, okay, I tried that method you told me to try. They're still not getting better. I kind of think maybe you should see them next time. But I do think they can deploy them in some cases and then like kind of keep a patient out of out of the room with me and save me time to go see. There's plenty of demand. So anything we can do to empower physicians who want to do some of that work, we're all for it.
So I just wanted to address the stigma and certainly people who are on this call that do work in the community. It would be awesome to be able to do a whole lot of work with stigma on so many different things. Addiction and recovery services have tons of stigma. So does homelessness, with people making assumptions and stigma for people who work with it or provide services. Parenting education, there's stigma with that. If I take a parenting education course, what's wrong with me, as
Right.
opposed to recognizing everybody can benefit, et cetera. So it would be great to have some more work with stigma in a lot of ways. Anybody else?
Well,
Um,
I have like a little soapbox speech on stigma, and um, it is, uh, we do lots of things. We've tried lots of things. We've done public service messaging. We've tried, um, obviously, in my case, we've tried putting the service in a different place where maybe it's not as recognizable and doesn't have the same taste and feel. But one thing you can do is you can start serving on community boards and start getting active in your community. My feeling is that mental health professionals and healthcare professionals more broadly don't get out into areas of the community that are unaffiliated with mental health. And so serving on your Parks and Rec board, serving on your Board of Zoning Appeals, serving on some boards and maybe even running for office like Margaret and I, offer opportunities for people to meet people in healthcare and people who do mental health. And, the people who serve on these boards are business people, real estate people, construction, all these kinds of fields, and they just don't meet people in mental health and they don't meet people in healthcare. And I feel like if more of us on the call here would do more of that, um, it would it would go a long way toward reducing stigma.
Thank you. Um, the bigger picture is with that too, integrating how we integrate our social services, not just mental health. And I want to do shout out to Bristol, Virginia, because of their state has required, they have FAP teams that get together on regular basis and look at individual families and try to integrate those services together. That's huge. At some point, we'll hear from Bristol, Tennessee Police Department beginning in January started with a Frontier Health worker who is working, and not only are they supporting that team, but kind of what Jodi said too, hopefully some of that culture will change because that learning will take place with the people around them. So it's not just being there, but it's what they bring to the table. Also, Craig Charles, I don't think made it today, but he's with Crown Cuts Academy, and I think just got a ETSU alumni honoring. But he does the barber and beauty services training, and they're training to know the resources so they can help send people. Yes, Washington County, thank you, Jodi, is also working
Such a cool
on that.
program.
And that's
Yeah.
huge. So anyway, our time is just up. So I want to thank Jodi tons for being
It
here,
was so
and
fun.
we'll share your PowerPoint once you give it to
Great.
us, and the recording will be there. And I want to say that we're certainly, they're in the room where it happens. We like to use that little Hamilton quote, and certainly Jodi's in the room where it's happening. The other thing I forgot to say at the beginning is just a recognition of the trauma and the mental health of everybody here today with what's going on in the bigger picture, that a lot of us are being affected by decisions that are being made, and decisions we don't know how they're going to be made for grant funding, et cetera. And it's very traumatic, and certainly affects our sleep and our families, et cetera. So, and then the last is we're looking forward to March, and that's when we'll have Healing Hands and Crossroads talk with us, and we can talk more if we need to after that. So we appreciate everybody here. We'll follow up with sending out the information, and next time, hopefully we'll have a little more time for networking. So might not with having two people. Tim, good to see you. So thank y'all very much for being here. I'm staying on to be able to copy the chat and finish up. So thank you very much.